Dr. Mbaruku, we can't hear you.
Okay. Good evening.
Good evening.
Okay, so
Good evening. Okay, so good evening. Okay, so good evening. Okay, so
I hear it repeating over and over.
repeating over and over, repeating over and over, repeating over and over, repeating over and over.
Okay, I'd like to welcome everybody to this meeting. I think it's because I was getting a lot of feedback from the computer. So I'd like to welcome everybody to this trauma series. Today we're going to have Dr. Oburu do a presentation. So I don't think we'll take much time, but in solidarity and honor of our colleague, Dr. Alan, who has passed away, I would like for us to observe a moment of silence. Starting now. Okay. Thank you, colleagues. This being the second CME that we've welcome everybody back on the schedule. I hope that to begin the series. So welcome, Dr. Oburu.
Thanks, Naima. Thank you very much for that introduction. Without further ado, I will just proceed to do my presentation. So, if anyone cannot hear me, please feel free to give me a feedback. Can you get me, Naima?
Yes, I can.
Fantastic, excellent. So thank you very much, and thanks for the opportunity, KOA, giving me the opportunity to discuss some trauma cases. I really wondered, well, what trauma cases I should present today, because my subspecialty is foot and ankle, but I still do quite a bit of general orthopedics, which is more than even the foot and ankle that I do. So managed to do some interesting trauma cases of late. And I maintain, other people may differ, that trauma is probably one of the most difficult aspects of orthopedics, really, because most of the elective stuff that we do are pretty routine. And when you get used to them, you can get the rhythm, but trauma always brings surprises. And trauma tests really our skills as surgeons. So I thought that maybe I should present foot and ankle trauma. Maybe another day for other cases. So I want to say that trauma can be challenging. This is an interesting patient. I'm trying to remember her age. She was, I think, in her 30s. And she sustained this relatively simple unimalleolar fracture. Really, any orthopedic surgeon can handle this. All it needs is a plate on the lateral aspect with a reduction of the fracture. Nothing else really with regards to treatment. But you can see that this was managed non-operatively. So it was managed just with a cast. And you can see that obviously that was not going to produce a good result because the medial clear space is far too wide. The deltoid there is gone. You don't even have adequate fibular length. The fibula is not reduced. The rotation, I presume, is also not addressed. And then things can really go south. So this patient proceeded to go elsewhere. And when they went to another hospital, this is what was done. So at the top here, we have what was done in the other hospital. I have no clue what they were doing. They did, I don't know, threw in some wires and everything. So this is what was done in one hospital. And then they didn't get a good result. So they went to another hospital. And this is what was done. I think they were attempting fusion. So finally, when I saw this patient, I said, we have a big problem here. You can see, obviously, the ankle joint is completely arthritic, okay? I'm not too sure of the subtalar joint, the talonavicular joint, which is not very visible here. I've got a series of x-rays. The talonavicular joint is also arthritic, okay? So the talonavicular joint is arthritic. She's got very little real estate with regards to the talus. So what did we do next? So what we ended up doing for her is we ended up doing tibiothalocalcaneal fusion, a TTC. And you can see that is our Phytos plate, which we have used for we ended up doing pantalar fusion, actually. So that's our TTC. That's a part where we fuse the ankle, we have fused the subtalar joint, but we have also fused the Chopard joint. You can see the Chopard joint has been fused. You can see this screw here is going into the calcaneocuboid joint, and this is addressing the subtalar, the talonavicular joint. So, but the problem is with this patient is this case was being done by my colleague, Dr. Wajiku Jombo, and I was giving an assistant. And the problem with this patient is that even when we did that, we found that the foot was still plantar flexed. So now we had no choice but to osteotomize the ankle joint. So we did an osteotomy of the ankle joint, okay? A closing wedge osteotomy, and then this has been closed. And how did we hold it? We had to hold it with a plate anteriorly. So this patient has unfortunately ended up with a tibiothalocalcaneal fusion, a fusion of the Chopard joint, and an ankle osteotomy. She has ended up with a completely stiff hind foot just because of a simple unimalleolar fracture that any orthopedic surgeon could have done. Now, what could have gone wrong or what could have been done differently? One, I think that we don't have control because of just the resources in our country that are limited. Sometimes these patients don't all get to see an orthopedic surgeon. So it's upon us to train a plastic technician that some things are really beyond the skills of a plastic technician. This is an unstable ankle fracture. It needed surgery. And unfortunately, the patient did not get surgery, and that is what the patient ended up with. But I think at this stage, surely, really, we could have done a proper ankle fusion. I'm not quite sure what was being done here. It's not for me to criticize, but really a proper ankle fusion would have been done. And it wasn't being done. At this other stage, an ankle fusion could have also been done, and it wasn't done. So we ended up with a pantalar fusion, okay? And doing an osteotomy of the ankle joint in order to be able to bring the foot up to dorsiflexion. So trauma can really go by. The last I saw her, the only issue she had was some wound problems, which is a bit surprising, but otherwise the foot is well aligned. Okay, now this is another case. Once again, an ankle fracture. You can see very clearly bimalleolar fracture. No one would argue again that this one, for reasons I have no clue. When I saw this patient, at that time, I have reduced the amount of ankle fusions that I do nowadays. I try my level best to reconstruct an ankle, even if it's quite badly displaced, as long as the patient has a joint line and there are no signs of arthritis, I try my level best to take the gamble. At this time, I decided to fuse this. That was a while ago. So I went to the patient to theater, did a fusion. So I used 3 screws, but for some strange reason, that wasn't holding. So I took a plate, that is the Arthrex plate for this frank fusion. And when I did this, I put it there. This was a few months after the fusion, but you can see the patient still has a problem because you can see that there is some loosening. You can see the halo there. It may be difficult to see, but there's a halo there, even over there, even over there. So there is some loosening already. And this patient was in pain, a lot of pain, even after 2 years. So what next? I think if you doubt whether your fusion has taken hold, the next step is to do a CT scan. So I went because of the CT scan was to see whether or not my ankle, whether my fusion worked. And you can see over here, if you look, you can clearly see that there is an ankle joint there. You can clearly see again that there's another ankle joint there. And you can see that. So the ankle joint did not fuse at all. But my worry when I did the CT scan is I did not like how the subtalar joint looked. So you can see how the subtalar joint looks over there, and I didn't like that. So I say that now what do I do with this patient? My ankle fusion did not work. I thought I did a good job, but evidently it did not work. So what do I do next? So I decided that I will proceed and do a tibio-calcaneal fusion, tibio-talocalcaneal fusion. So I prep the ankle joint, prep the subtalar joint, put one long screw over there and a filer's plate there. And this is the patient 6 months after surgery. So sometimes we have to accept as surgeons that what we may do may not necessarily work, and we have to come and revise it. Okay? Now, this is an interesting case. This young man was an investment banker. He was playing football and he sustained the injury as shown above. So, by the way, they used to tell us that you should not even see this injury, this kind of x-ray in the first place. And therefore, but anyway, this is the x-ray they did. You can see it's even difficult to tell the anatomy, what has happened. That's why we tell our medical students, first reduce the fracture, then do an x-ray, even a CT scan after you reduce the fracture, then you're able to see really what's the injury. But you know, there is that suspicious fragment over there, okay? And obviously that is gone and that's gone. So I thought we were dealing with a trimalleolar fracture. Spoke with the registrar and I said, why don't we do a CT scan? And you can see from the CT scan that this is not a small posterior malleolar this way, you know, that's not a small posterior malleolar fragment. So I decided to fix this. Now, there is debate really, the reason I presented this case, there's debate really about what we should do. Should you fix the posterior malleolus from the front? Should you fix it from the back? What I was taught by the registrar was the best way of addressing the posterior malleolus is to fix it from the back. So I did a posterolateral approach, you can see, and then I did a plate here, okay, that goes all the way from the back, and it buttresses the posterior malleolar fragment. But when I was operating this patient, he had a funny fibula, which kind of like just twirled and spiraled around this region over here. So the normal locking plate was not working. I was forced to use an anti-glide plate. So this really is an anti-glide plate, okay? So it's not on the side, but it's really at the back. I don't like using anti-glide plates. I only use them when sometimes I really am desperate to get fibular length. And in this case, the other plate was just not fitting properly. So I use this as an anti-glide plate, okay? The reason I don't like using them is just because they irritate the peroneal tendons. So that is a good result that I think we relatively got over there. So I think that, you know, posterior malleolus fragment, it only makes sense to address them from the back, I think, and it's not a difficult approach. You basically go between the lateral malleolus and the Achilles tendon. The only thing you have to be careful there is a sural nerve. Once you are in there, you go in between the peroneal tendon and the flexor hallucis longus. And it's important to really retract the flexor hallucis longus, yeah, because that is what will ensure that you protect the tibial nerve. It's not a difficult approach, you know, once you do it. How do you do it? Do you do it prone or do you do it lateral? What I was taught by my teacher, Mr. Rocco, many years ago, was to do it prone, but I prefer to do it lateral because then I can access the medial side if I need to do a medial malleolus fixation. What I do is after I do it lateral, I just turn the patient back to supine. Okay. Now, this is another case. This is a case that was referred to me by a good friend of mine, Dr. Kimani. And this patient had a pilon fracture, you can see. And basically, we went and did an anterolateral plate. But to address the posterior malleolar fracture, what we did was we went ahead and we plated the back. So you can see, you can even put a T-plate there, and it comes right at the bottom, and it pushes the fragment there. So sometimes though the trauma, even in foot and ankle, can be so crazy, you're not sure what to do. This patient was about a 31-year-old gentleman. He fell, sustained from a height. He sustained a left ankle a fracture, which an orifice done. I was not involved in that. But what one of my colleagues called me to do was to be involved in this calcaneal fracture. So you can see this is really a bag of bones. Where do you start and where do you stop? It's all over. I don't know how you can classify this. Maybe the registrars can tell us, but this is really almost beyond Sanders. So you can see, what did we do here? So we did extended lateral approach. This approach is falling out of favor many a time. People are now using a sinus tassi approach. One of the problems that we have is we don't have the sinus tassi plates here, the plate for the sinus tassi approach. But this is what we did. And that was Arthur's closer. But what we did intraoperatively is you can see that one important thing about this approach is please be very, very careful of the soft tissues, okay? Because this can come to really haunt you. So be very careful of the soft tissues. And then what I decided to do was to do a fusion. So I denuded the cartilage over there, denuded the cartilage over there, and then fixed the calcaneus. So the calcaneus is fixed with this calcaneal plate. However, I put through screws there to do my subtalar fusion, and you can see that's what we've done. So, you know, it's debatable. Some people may have said that, oh, maybe what we need to do is just to let it heal and be, but I can tell you doing a subtalar fusion on that is not easy, especially when it's marginated. So this patient, this was relatively easy because once you have reduced it, what you do is you put your plate, okay, you avoid the holes where you think your screws will go, and then you put your screws after that. So that was so that sometimes it's, you do something which is unconventional. Then comes the thing of old fractures. What do you do when a patient has an old fracture that or either has been fixed, has not been fixed in the proper way? Where do you go? What do you do? In my younger days, or I don't know if I would say in my younger days, 5, 6, 7 years ago, this would have been for fusion. But I have shied away from fusing these fractures. So this fracture had been fixed about, maybe this boy was about 17. The fracture had been fixed about 7, 8 months or 9 months prior to this. You can see the fixation. You can see that the clear space is there. You can see that the fibula is shortened. Okay, so what did we go and do? Well, I think that there was no problem of fibular rotation here. It was just shortening. I didn't have my tools, a good laminar spreader, but I used this, reasonable. It's from the Artflex set. So what you do is I did an osteotomy there, put my laminar spreader there, jacked it out. But over here also, I must emphasize that you need to clear the what? You need to clear the syndesmosis. So that was our gap there. I took graft. The graft I took was from the proximal tibia. I do some iliac crest graft, but I really avoid it because of the mobility associated with it. I put my syndesmotic screw, and that is our fixation. This is the boy 2 weeks after I saw him in the clinic. Okay, which I think is a relatively good result. One of the things that I find, especially when you're removing the gap here, obviously you're interfering with the delta, and sometimes you may feel there's a bit of a tilt. over there. But I think that this is what going. I think I saw this boy last week or the week before. It lasted 2 weeks post-op. Now, another way you can do fibular lengthening, and this I've done in the past, is like in this patient. I don't have the pre-op X-rays, but this patient had a shortening of that, and this was a Weber C supination external rotation stage 4, perhaps, and ended up with a malunion. And what I did is you do osteotomy in that direction. You can see my laminar spreader. I've opened it up. Then you fix distally. Then after you fix distally, you come proximally here with the laminar spreader. Okay, so that's my laminar spreader there. And you put your screw here. Okay, so I've jacked that up. Okay, and that will allow you to gain length down over here. And then you're able to fix that. Okay, so in this case, no use of bone graft, and you fix it immediately. And the patient is doing quite well, actually. I spoke with the son much later after that. Now, this patient, I don't have the history, to be honest, but it was a patient of Mr. Rocco. And this patient had a strange fracture here. I just have some scans. So you can see here, this is the calcaneocuboid joint, and you have a depression over there. You can see here it's a bit comminuted. And on this sagittal view, we can just see that, okay? So there's a depression there and there's a depression there. So what do you do with this? I remember Mr. Rocco asking me, what's my opinion? What should we do? I quickly fired this question to some of my colleagues, and that's important. Some of the very good surgeons that I know, they always ask people, even some of the surgeons that are much better than me, they always ask me, what would you do? What should you do? And I think the lesson to learn from that, you can't know everything. And, people can always give you a different opinion. So I think one of the people advised that what we need to do is we need to go open it up, jack it out, okay, elevate it, and then we put that's what we did. We put a spanning plate. Now this plate spans from the cuboid, which is around there, and the anterior horn of the anterior process of the calcaneus, which is over there. And you can see that that's how we did. I am not sure. I did ask Mr. Rocco before this presentation. I think the plate must have come off by now. Okay, but also one thing that I would like to mention, if you look at this patient, they had this fracture here. You can see that fracture there. For registrars, that's known as a snow borders fracture, which is the lateral process of the talus. And for that, we put a screw like that. All right, so that was our screw there for the snow borders fracture. I don't know if that really counts in Kenya, because we don't have snow borders in Kenya. But anyway, so sometimes you get patients with crazy injuries. This was a case I did recently. This gentleman had a calcaneal fracture. They also had Weber C fracture, which was quite long. And on the other hand, they had a calcaneal fracture. So multiple injuries at the same time. So in this case, crazy amount of trauma. We started with the ankle fracture. For Weber C's, I prefer to use plates, even if, unless it's a Maisonneuve fracture, which is way, way up there. If it's something that's even just in the middle, if I can plate it, the better. Obviously, you always have to look for the nerve because it is there. After we plated that, we went and we did an extended lateral approach, and we did a plating of the calcaneus. You can see that. Not a bad. We've restored our Boller's angle. We've restored our descent angle. I think the calcaneus is out of varus. But for the other side, because I just didn't like the soft tissues, they look swollen and everything, I decided to just manipulate it and to fire screws to at least obtain some length. So I fired 3 screws. You can see the Harris view. Maybe a bit more varus. It's a bit difficult to say because taking a Harris view can be difficult. But anyway, I think a reasonable alignment nonetheless. Now, this was an interesting case. This case I was referred to by Dr. Guillaume, who works in the Kagundo. And this gentleman had this injury, a terrible injury. This is a pillow. You can see that's one fragment over there. And then you can see, if you look closely, that he also has a talus fracture, okay? He also has a talus fracture. So it's a really bad injury. It's a really bad injury. You can see all these, you know, all that is communicated. Now the problem is when I saw him, he's about what? He was about 8 weeks. So what do you do with this? At 8 weeks, it's really difficult to you know, to deal with this. So, you know, if you are to ask a registrar, they will give you all sorts of answers, go plate this, whatever, the osteotomy has been done for you. But at 8 weeks, if you've been doing this job for a while, you know you're pretty stuck. So what did I decide to do? So I decided to do something which is a bit radical. I decided to do a tibial-talocalcaneal fusion with a nail. The problem that we have is we don't have good nails for tibial-talocalcaneal fusion. I hate using the tibial nail, which is what I did here. So you can see that this one screw here is just on the top next to the subtalar joint. This screw is a good screw because it's in the talus. You can see that now. So in order to solve that problem, I usually put two screws, and they usually come from the top. But this time, for some strange reason, we're not able to come from the top. So you put one from the top and one from the bottom. So this screw, part of it was done by myself, part of it was done by the registrar. And actually, if you look closely, it has missed the bone, which is very, very unfortunate. It has missed the bone. You can see that, because this is the calcaneus. And the screw is just on the edge of the bone, which is a shame. But this one that was done by my other registrar, Momanyi, who was scrubbed, was done very well. You can see it has hit the calcaneus very well. So at least that adds to the stability. So that's what we did. I saw this gentleman on Monday in the clinic. I did this in Kikuyu Hospital, and he's doing quite well. The wound looks good. The x-ray looks good. I think he will go to heal. You know, he really had no good choices. And the question is, should you prep the ankle or should you prep the subtalar joint? I think some papers describe it as you just shove a nail without doing much prep. I try to prep the ankle joint, and I try to put an incision here so that I can access the subtalar joint and do some prepping. It just makes me sleep better at night. Finally, ladies and gentlemen, these fractures can have very different outcomes. You know, one patient can get a fixation. This is a gentleman I operated about maybe 4 years ago, I can't remember. He had a talus fracture. You can see how comminuted it is. But I went ahead and we did this fixation, you know, with what is it called? Fully threaded compression screws. And you see we've restored the anatomy quite well. This, however, is a different lady who was in Meru, and she had this fracture. And, you know, this was managed with a cast. You can see it was a terrible, terrible, you know, injury, Hawkins 3. And what happened is we ended up with a fusion. So I ended up doing a tibial-talocalcaneal fusion, which has healed very well. You can see it has healed very well. But what the lady once asked me, yeah, thank you very much, my foot has healed, but why is it so stiff? It's really, really stiff. So we really have to treat these trauma things with utmost care and concern, because when we don't do it well, you know, the results for the patient can be totally devastating. You can imagine the first case that I showed is a patient who started with a lateral malleolus fracture and has actually ended up with a plantar fusion with an ankle osteotomy, you know, at the end. That is really a disastrous and an unacceptable result. Thank you very much.
Thank you very much, Dr. Oburu, for a wonderful presentation. Indeed, trauma can be traumatic. Am I audible?
You are very audible.
Okay. So yeah, as I was saying, trauma can be quite traumatic. I think, to the surgeon as well. But I think those were excellent cases. Thank you very much. And it looks like some of the fractures just get more and more complex. I don't know if this happens because you get more and more experience, or that, you know, the fractures get more, the complexity increases more with motion, or, you know, vehicles or whatever it is. But I feel like those are things that maybe sometimes we would see in textbooks, sometimes you don't see them in textbooks, sometimes they come up to you in a clinical practice, and, you know, you're just left wondering what to do. But thank you very much. We look to share more and discuss more. So I saw that there were some questions. The first one, I think, was by Dr. Musere. And his first question, I'm not able to access them anymore, but his first question was, I think, about the second case that you were presenting. And the question was about when the time of injury, or the duration between the first and the second injury was. And then there was one also from Dr. Wafula. I think I had seen these in between. And it was about the calcaneus fracture, I think, and it was about a fusion and the duration that it took to fix, and he was asking whether the 10-day rule still applies. So I think if you have those questions and access to them, you can also refer, but that's what I have picked so far.
So I'll talk about the first question. You say Dr. Museve was asking about when the fixation.
Yes, yes. No, between the first and the second injury.
So there are no two injuries in the first question. This patient was a 50-year-old with, the lady with a 50-year-old with a bimalleolar fracture.
Yes.
She essentially had, I cannot remember the duration. That's a good question. I think it was many months. Mm-hmm. So at that time, look, it really varies. Do you preserve the joint or do you fix? I think as much as possible, you should preserve the joint. But you should know, you're already starting from a bad position. So you should be well armed. You should know what you're going to do. Because you don't want to fix a joint which is going to become arthritic tomorrow, where somebody looks at the fixation, or you look at the fixation and says, I have not improved. There are times when you can go in and say, look, I'm going to fix the joint. I think you should always be prepared to fuse it, just in case. I think the more and more you do this job, I have fused maybe 1 or 2 or 3 ankles, which have ended up needing subtalar fusion in 2-3 years. And, that's really a disaster. A tibial fusion is a good operation for the surgeon, very good, but it's a bad operation for the patients. You don't want to fuse things you don't have to fuse, because eventually it becomes, you get arthritis of the Chopard joint, then you need a plantar fusion. Then you get arthritis of the midfoot. Are you going to fuse the midfoot? The patient is working on a block of wood. So I try my level best now to fix these old fractures if I can. Having said that, after this, my initial fusion failed, and it just failed to take. So, and that took 2 years. The patient was still in so much pain. So I told the patient, look here, we could either revise the ankle or we could fuse the joint below the ankle. And there's a good chance that, also sometimes once you fuse an ankle, you lose real estate in terms of the talus. So I had to do a TTC, a tibial calcaneal fusion. The other one about, for Dr. Wafula is, look, I think this patient had been in the ward because they've probably been in the ward 10 days or something like that. And the surgery itself does not take too long. I would say, how long would that take? Maybe an hour and a half to 2 hours, maybe 2 hours. Because, you just want to prep the it's not like fixing a calcaneus, because when you're fixing a calcaneus, you need to be dead accurate with your posterior facet and the anterior process. But in this one, you're debriding it, and then you put your plate, and then so the surgery itself does not take long. But having said that, I have not done many. It's not a situation you get caught in so many times. The only other one I did was one I did with Mr. Rocky in Aga Khan about 2 years ago. So it's not a common thing. Yes.
Okay, thank you. I think there's a question again. I'll take maybe Zachariah's question first. We know that Zachariah likes to manage things non-operatively, and we are grateful for that. But he asked whether some of these fractures can be treated non-operatively, or whether some of these fractures can heal in a conservative manner.
I think with ankle fractures, it's straightforward. If you have a talar shift, if you have more than one malleolus fractured, you need to fix. There is no compromise with that. The only tricky one is supination external rotation stage 4. Is it supination external rotation stage 2, or is it stage 4? And that's really difficult to say. And I'm sure that, Neema, you've faced that situation many times. When I was in training, by far and large, because I trained in a place where it was a national health service. And so the resources, even if it was a Western country, the resources were not they were not so immense that you could not exhaust. So by and large, many patients with Weber B fractures, if I remember correctly, we managed non-operatively. And I just never saw a lot of arthritis, to be honest. Many patients with Weber B. So it's a Weber B, and you can't really tell. The talus does not look shifted. That's what I'm saying. If the talus looks shifted, that's straightforward. Now, I think that I still struggle with decisions with Weber B. But what I tell guys, look, if you're in doubt, fix it.
Yeah.
Because, sometimes even I'm sure some of your colleagues are asking you, oh, is the talus shifted? You can't tell.
Yeah.
You do a mortise view, you still can't tell.
Yeah.
So I fix them. I just fix Weber B's. I think I overfix them. I hate being asked that question. A Weber C is straightforward, isn't it? Or a bimalleolar fracture, that's straightforward. There's nothing to think about. Because at the end of the day, you also don't want to do an operation that the patient does not need. But I think Weber B is, I fix them. And when we had one of our, there is a conference that's coming, Steps to Walk in May, that is foot and ankle. And when we had one of the speakers there who came from Duke University, he says that because they do so many ankle replacements in Duke, they found that they tend to really fix ankle fractures because they've seen arthritis from many ankle fractures, which maybe would have just benefited from a fixation. Obviously, as a surgeon, as a surgeon, sometimes there's a financial incentive, which I don't think should guide us. But,
I tend to think, from the experience of not fixing an ankle fracture, that you'd pretty much rather fix it than not fix it.
I think if you're in doubt, I think. Or follow the patient very closely, especially week 1, week 2.
Right. Another question from Dr. Wafula, and he asked if there are any tricks in fusion of the neglected ankle fractures, as reduction is a tad hard with fairly porotic fractures and challenge with, what are the challenges with screw fractures? He asked whether you would go for an angle device straight up.
So the surprisingly many ankle fusions that you do, surprisingly, the bone is not bad. That's been my experience. In this patient that my ankle fusion failed, that bone was bad. But many times, Wafula, the bone is not too bad. Now, the tricky thing is reducing it. First, I think you should do it with imaging. I think it's very difficult to do an ankle fusion with imaging. The bones can fuse, but is it reduced? I tend to go anterior approach. I used to go transfibular approach most of the time. I did that for a long time. But about 3-4 years ago, I changed. So I just do I do an anterior approach. Not all the time. I still do a transfibular sometimes, but I do an anterior approach. And because it helps me with, if I can align the medial aspect of the talus to the shoulder of the plafond, then I know that I am reduced. Yeah, some are difficult to reduce. Obviously, if you go anterior approach, you need to osteotomize the fibula to allow your foot to swing medially. Some are difficult to reduce. Some are relatively straightforward. It just depends. There's one I was doing with Dr. Rocco and Dr. Mohamed Ali. I think it was this Sunday before this one, and it was fairly straightforward. But then it was very difficult to reduce because you not only want to reduce it in the medial lateral aspect, but you also do not want their foot, because sometimes you do an ankle fusion and you find your foot is posterior to so their weight is being transmitted to a plane on the anterior or to an axis that's on the anterior aspect of the ankle. So I think reduction is can be sometimes tricky. Yeah, but when you put in the time, you learn the tricks.
Right. Okay, so from our chairman, Dr. Kilonzo, he asked, is there a time frame within which a neglected ankle dislocation should be managed by fusion? And the next question he asked is, when are we likely to start ankle replacement in Kenya?
So I think number one is a dislocation is different from a fracture, malunited fracture. Though a malunited fracture may be dislocated. So let me say this. When you have a dislocation, dislocations are difficult. It's very difficult to put a dislocation back in place. However, a malunited fracture is different. If you have a fracture dislocation, that is more of a dislocation. And those ones are difficult to realign. You understand? Because there's so much gunk in the tissues. How are you going to remove the gunk in the front, in the back? It's crazy. Now, if you have a malunited fracture, that you can attempt to fix. What really determines is, one, is there arthritis? That's number one. Yeah. That's the main thing that will determine, is there arthritis? And then, do you think, I suppose the skill of the surgeon that may determine. And number three, I think equipment. So for example, if all you have in your arsenal is a third tibular plate, you know, a third tibular plate just cannot work with lengthening. It is way too flimsy. Well, if you want to lengthen the fibula, a third tibular plate will not work. You need a proper rigid plate. That's why you use a fibular plate. Yeah, or if the fracture is higher, a DCP, small fragment DCP, but a third tibular plate will not work. Yeah, so many, and then you need the equipment also. Yeah. Ankle replacements, I think eventually they'll come. I think the problem with ankle replacements or any replacement of joints which are not commonly replaced, the problem is whether or not it's economically viable for the companies to bring them here. Because sometimes they may ask, given how many hips and knees we do, and they say, wow, if we bring the ankles, how many, what will, you know, it's not worth bringing. But anyway, eventually it will come for sure. Yeah.
Okay. I see a few more questions. So Zachariah wants to know why there are few foot and ankle surgeons in Kenya. And then I'll ask also on behalf of Dr. Hamed, should we repair soft tissues as well, you know, like the torn ligaments, or should we just fix the bones in an acute setting?
That's a good question. I think, well, let me answer Zachariah. It's just I think, you know, look, it's people, they in a few years will have many foot and ankle surgeons. I don't think we'll have many foot and ankle surgeons only. I think we'll have foot and ankle surgeons, shoulder surgeons, pediatric orthopedic surgeons, sports surgeons, pelvic surgeons. We have to give credit to the people who started orthopedics in this country, the professors. Many of them are now retiring or retired. They started, got the ball rolling, and then the next people, I think the generation after us, it will be standard to you'll get a foot and ankle surgeon in Kenyatta, one in Coast General, one in Russia. They will just be there. It will be just the nature of the game. So there is a start for everything. Now, should we repair the soft tissues as well, or like torn ligaments, or just bones? Now, to be honest with you, Ahmed, I'm not quite sure I know the answer. So with regards, let's talk about the syndesmosis, which is most commonly injured. I put syndesmotic screws. This is another case where if I'm in doubt, I put a screw. I don't like using the syndesmotic screw if I can avoid it. So if I do a case, which is a private case, and the patient has a good insurance, I usually use a syndesmotic tightrope. Some people may argue that a syndesmotic tightrope is expensive, but it's not expensive because most orthopedic surgeons believe we should remove the syndesmotic screw. I don't usually remove it. I give the patient the option. I say, look here, we can remove it. We may leave it there. If we leave it there, it may break. If it breaks, it doesn't mean anything. So to avoid that discussion with the patient, I prefer a tightrope, because a tightrope no one is going to remove anyway. So so that's with regards to the syndesmosis. Maybe a question, Hamed, is what do you do with the deltoid? As a rule, we don't fix the deltoid. As a rule, we don't fix the deltoid. Have I ever fixed the deltoid? Yes. And in that case where you remember the case I did where I did the old fracture and you've cleared all the gunk immediately and you feel like you have a gap with regards to the deltoid, and the deltoid was stretched anyway. I've ever fixed the deltoid? Yes. I remember when I was a registrar working in a different country, and that country had more money than the one that worked before. You could just put a suture anchor and repair the deltoid. I think it may improve your X-ray a bit. Whether or not it clinically helps, that I am not sure. If you have an ATFL injury that's acute, I think the standard practice is you don't repair acute ATFL injuries. You let them heal. You only do the chronic ones. And even the chronic ones, you start with rehabilitation. Many of them heal even without surgery.
Okay, so I think the questions have been satisfactorily answered. Thank you so much, Dr. Oburu, for sharing your vast experience with these injuries. Looking forward to having more of these trauma sessions. We need refreshers every so often. I don't think there's anybody who can actually say they're a custodian of knowledge, but thank you so much for sharing this with us, and even for the points of light humor in some of your presentations. So I think there are also some greetings or appreciations from Dr. Wafula. Thank you so much. Thank you everybody for, I see one more. Dr. Mbogori Makena, can we unmute you and you can ask?
Yes, good evening. Thank you for the presentation, Dr. Oburu. I just want to remind the team about the screening that we're having this month.
Yes, so thank you very much. McKenna, do you have the poster with you, the exact dates? Because I need to go back to the poster you sent me.
Yeah, sorry. So we're having the Foot and Ankle Conference that we had in 2019. Last year, we didn't have it because of the COVID, but we are trying to have it this year, and everyone is welcome to participate. We'll be having the screening on the 15th of March, 2021, and I'll be sharing a poster shortly at PCA Kikuyu Hospital from 9 a.m. So as well, if you have any patients that may benefit from foot and ankle consultation and surgeries this year, you're welcome to send them over. The screening will be free of charge, no consultation, but they'll need to have NHIF so as to be able to have the surgery done. So just wanted to remind you that, Dr. Oburu. Thank you so much.
Thanks, McKenna. Thank you very much. McKenna is usually on top of the board. She's the one who does all the organizing with Wanjiku. So, thanks a lot, McKenna. Now, yeah, please, guys, we'd really appreciate there are many patients who are suffering out there with cable virus feet, flat feet, hallux valgus, things which can really be sorted operatively. Please feel free to send these patients. Any patients who we will be doing this is going to be free. The surgeries are going to be free. As long as the patient has NHIF, they are not going to pay anything for the surgeries. So please send these patients, we can screen them. We'll be having this conference. The other thing is also about the conference. The dates are already there. We'll be sending a poster soon about the dates. It is fast come, fast served. The spots are going to be limited. At the moment, we only have 20 spots. It's a very, very good conference. I've attended many meetings. This is really, really good. The people who attended the first one will tell you. There will be 1 day of lectures, 1 day of patient evaluation, food patients, because sometimes you don't know what's happening with the patient's food. There will be 2 days of operating where we'll operate about at least maybe 10 to 15 cases, and then there'll be one cadaveric day. So once McKenna will put out the poster and everything, guys, it's fast come, fast serve. But meanwhile, send us the patients for screening.
Okay, I have a question. With the NHIF, should the payment be updated for 1 or 2 years?
That technical aspect, I do not know. I don't know if McKenna, you're aware. I'm not sure. Is she, McKenna, on? I'm not sure. I think, look here, to be safe, it's not so expensive. Obviously, maybe I'm talking as a doctor, but yeah, maybe it's a good idea to have the patient updated. They lose nothing by updating anyway. They're going to pay for that. Mm-hmm. So yeah, but please, we need this. For those of you who do private cases, some of these foot operations, if you do them privately, they would go into the region of 500,000 just because of the equipment alone. So please send the patients.
Okay, I can hear I'm being called in the background. So, thank you so much. I would like to wind up this session. I would like to also give some feedback. We've got some very good feedback that the topic was fantastic, a fantastic choice. The presenter did a fantastic job, and the overall session was very good. We've had very good attendance. We've had a participation at one point of 94, and now we're at 65. So thank you very much, everybody. Looking forward to having another session that's this well attended and this well done.
Thank you, Nema.
All right then, closing off. All right then. Thank you so much, Dr. Oburu. Thank you, everybody.